So this is an area where all of us, primary care, specialty care, ancillary care, can work together to provide better access. And that's the referral process. Here's a kind of unfortunately typical referral scenario where the patient is there not knowing why she's there, and the specialist doesn't know why she's there either because there's no records. So all of these unknowns create delays and gaps in care that can land the patient in the emergency department. If you don't know why the patient was referred, then you don't know how urgent it is. And you could have a really sick patient waiting, getting worse, ending up in the ER. Maybe the patient lands in urology and she needed nephrology. So a lot of times they don't ever make it to that secondary referral. They get in the hospital or in the ER. And then we have what we call that low value referral, where there's no information and it's low value because you can't benefit the patient. You can't help the patient in any way. You end up repeating what's already been done, which adds to waste, and then it adds delay. The patient's totally confused, doesn't know what to do, feels horrible, didn't get any better with that appointment, and goes to the ER. Now, it's bad for us, but all these unknowns are so confusing and intimidating to the patient. Why should they even go? Where do they park? How do they get in the building? What's going to happen? It's scary. They know about the ER. So this can lead to no-shows and cancellations. Over 20% of referrals are never completed. And those patients have delay in diagnosis, delay in treatment. The patient ends up having higher acuity care than they really needed, and we end up having higher liability. So some of the strategies to help us all with this, and I'm going to call out a couple on this slide. The first one is to make a referral about taking care of the patient and include the patient in the process. Tell them what the referral is for, tie it into their goals for their care and their life, and ask them if they're even willing to go. And then the second strategy is to make it as easy as possible for the patient and reduce as many unknowns as possible for the patient. So giving the patient something that says, this is what a neurologist is, or this is what lupus is. And then really important, and Beth can talk more about this as well because they've done this at Denver Health, a safety net hospital, and they've dramatically reduced no-shows for new appointments by giving the patient some information about that clinic, where to park, how to get through the building, and get to the clinic contact information. And then another critical strategy is to be sure that the specialty practice is made aware if the patient has hearing or vision impairment, if a caregiver or a care manager, transportation needs, etc., needs to be involved. Now, this is one of the most powerful strategies that we found, and it's pre-consultation. And there's kind of three ways to use pre-consultation. One is for the requesting clinician or practice to ask the specialty clinic, is this even somebody you see? Does this patient even need a referral? If so, what's the right timing and what's the right workup? Now, even if that kind of questions aren't asked ahead of time, every referral that comes in should have a pre-consultation review by the specialty team. You know, are they the right specialist? Is it even a necessary referral? Is the clinical question clear? Do they know why the patient is being referred? Is the necessary data there? And how urgent is it? And if they don't have that information, then take the opportunity to get that information to make that a high value appointment. And then the third is, I'm going to refer this patient to you, but they're really sick, and what can I do until they get in to see you? So help that pre-consultation to help with that urgent case. Now, kind of a linked necessary strategy is to have the capability to schedule based on urgency. It might be okay for a restaurant to do first call, first book, but in medicine, we need to do triage. And part of that starts by having our front desk scheduling people be part of the team. We can give them a list of conditions that are urgent, intermediate, and routine. And don't worry if you don't get every condition on there. You're allowed to talk with each other. Okay, and then when these come in, I'll tell you how it worked in my practice. We had urgent spots in my practice. Some people have on-call clinicians. Some people maybe have worked with a nurse practitioner who's free to see these urgent ones, but there needs to be some capability to get these urgent patients seen. So if my front desk person saw an urgent condition referred, she'd right away let me know, can I put it in the next urgent spot? If we didn't have an urgent spot, I know right away to start thinking, can I stay after? Can I come in early tomorrow? How are we going to see this patient? Now, if we didn't have an urgent referral, we moved an intermediate referral, what we called our move-ups, into that spot, which opens up a downstream appointment and continues to help with access. So that not every clinic has that, and we learned that a lot of the big academic clinics that use central scheduling don't have a way to see patients based on urgency. It might take some creativity, but it needs to be done. Okay,